It is indeed a pleasure to be here as alumni of the College of Public Health and Department of Epidemiology. So just outline of my talk, I'm going to reminisce a little bit about my time at UAB since I am an alumni, but Dr. Shrestha has given some background on what I did at UAB. And then I'll move on to just give a little background on what I call population on the move, defines certain terms like immigrant, refugee, resettled refugees, some of the terminology that I'm going to be using related to some of my work. And then I'll talk a little about, when you look at the health among these population, what are some of the things we need to think about given the circumstances in which their circumstances, the whole issue of migration. And then specifically talk about one of the health disparity issues in one of the subpopulation, what's termed as resettled refugees in the United States, looking at exposure to childhood-led exposure in Ohio children, resettled refugee children in Ohio. And then I'll summarize the talk, and hopefully we'll have some time for discussion. So just moving on, as Dr. Shrestha said, I am an alumnus of the College of Public Health. I did my master's in epidemiology and what is called international health. I was between 1997 and 99. I see Dr. Waterboard on the screen, him among many other, the retired professors. I spent my 10 years at UAB, doing my master's as well as my PhD. I completed my PhD in 2007. And during that time, I also served as a graduate assistant program manager and program director for Sparkman Center for Global Health. It used to be called John J. Sparkman Center for International Public Health Education. During my time there, we changed the name to Global Health. As you can see, I have one of the degrees in international health. Now it's called Global Health. And as Dr. Shrestha says, I was trained, my primary focus during my training was in infectious disease. My dissertation was related to HPV persistence and clearance among HIV positive women in Alabama. So with that background, how did I get into the whole issue of immigrant health and refugee health? So it's, as you can see, I am someone who is interested in both in epidemiology and you can call global health, international health. So this topic seems to combine both of those interests, and it happened during the time I took a position at Kent State University in 2009 after graduating from UAB. The time coincided with when a large number of Nepali-speaking Bhutanese refugees were being resettled in the United States. The process started in 2007, and in 2000 and 2009, there were refugee population being resettled in different parts of the country, including Ohio, specifically Northeast Ohio, in Akron metropolitan area, as well as Cleveland metropolitan area, where the Kent State University is in Northeast Ohio. And initially, as I'm sure by my accent, you all know, I am from around here. I'm originated from Nepal. I came to the United States for college and then graduate school. And because I spoke Nepali, and I started engaging with this community more as an unofficial social worker, helping the community navigate the new surroundings. And at the same time, as I was interacting with the community, I started seeing some of the issues, health issues that may be occurring or can potentially occur. One of the example I can give you is when you go to any Nepali or Bhutanese Nepali household, as a welcoming, they'll offer you tea, and if you don't want some tea, they say, well, I have some juice. Would you like some juice? And then, when you look at what they were offering as a juice, it would be a big bottle of Sunkist with 10% sugar, 90% sugar and some juice. And I started thinking about what are some of the health implications of some of the new environment they're going to be living in. And with that, we started looking at some of the nutrition and health issues. And in the past 10 years, we have worked on several health issues in this population in Ohio, as well as the refugee population in Nepal, including HPV and cervical cancer, childhood lead poisoning, nutrition and chronic diseases, pregnancy, and the health issues around pregnancy and childbirth, and oral health. So some of the publication that I've listed, and I've collaborated, as Dr. Shrestha says, with UAB, as well with Dr. Shrestha and NFCC to do some of this work in Nepal as well. So that sort of gives you my transition from what my PhD training was and my current interest on my current research interest. So let's talk a little bit about the population on the move, or what do I mean by that? If you look at globally, about 1 in 8 people, or about 1 billion people globally, are on the move. That means they are somewhere than the place they were born. They have moved to a new place because of various reasons. And this movement can occur within the border of your own country, that may be internal migration, or you're an internal migrant, or can be an international migration. So of the 1 billion, about 700 million are within the boundaries of your own country, and 280 to 181 millions are across the international boundaries. And if you are paying attention to what is happening in China right now, China is going through their COVID surges right now, and with the coinciding of the Lunar New Year celebration, there's a large, hundreds and millions or tens of millions of people are moving from urban areas into the rural areas, where they had migrated from work, and going back home for celebration. And when there's a large movement of people, whether it's internal or external, it has health implication, both in terms of the infectious disease as well as the chronic diseases. So of the international of the people, people move for different reasons, and 84 million people in the world are forcibly displaced from their place of residence. That means they are displaced because of the conflicts, war, political unrest, or natural disaster. And this displacement can happen within your own country or outside your own country. When it happens within your own country, then you're classified as an internally displaced person. So when there's hurricanes down in Florida or Louisiana, if you remember Katrina, and there are a large number of people from New Orleans were internally displaced. But if you cross your national boundary, then you become a refugee. So of the 84 million people who are forced to move from their place of residence, 27 millions have crossed the national boundary, are refugees. And for about 5 millions are what we call asylum seekers. And I'll define these terms a little bit later. Basically, the difference between an asylum seeker and a refugee is refugee, you have it's a legally defined, there's a definition you recognize, versus asylum seeker, you're seeking that designation. So you're in a state of limbo. You have crossed the national boundaries, but you haven't been classified as a refugee yet. And almost half, or 40%, are children. So there's large number of children that are forcibly displaced. About 1 million children are born in what we call refugee life. That means your parents are refugees, moved across a national boundary, and you're born after you cross the national boundary. And that has implications, because then you're not you are essentially a person without a home or a country. So when you talk about migrants, so people on the move, migrant, you have two aspects, immigrants and immigrants. And I am a migrant, I emigrated from Nepal, and I'm an immigrant in the United States. But there's not a, when you talk about what a migrant is, there's not a universally accepted legal definition of a migrant. In fact, if you belong here in the United States for 15 or 20 years of my life in the United States, I was classified as what you call a legal alien. I don't think that term is used anymore, but I used to be illegal. I came here legally because I was a student, and I was classified as an alien because I was on a student visa. It's only after I, even so, if you're here on a student visa, from a US perspective, you're actually not a migrant, you're a guest visitor. Or if you're on a work visa, you're actually not a, from a US legal perspective, you're not a migrant yet. But so there's not a universally accepted definition, but from a lay person's or definition or operational definition, you can have any person who changes their country of usual resident would be classified as migrant. So whether that definition, regardless of what the legal status is, how long that migration takes place, and what the causes of the migration is, that's perfectly a good legal definition. But from a working definition, it may not be a legal definition, but it's really a highly sensitive definition. But talking in terms of epidemiologic term, it's highly sensitive. It's going to capture everybody who is not in the place of usual residence. But it's not a specific definition in that it's going to capture everybody. But then when you have to look at the health issues, it's not, you're going to have a variety of reasons why people move, and the definition is not specific enough a lot of times for epidemiologic reason. But you migrate because of work, study, join family, or for a lot of other reasons, poverty, political unrest, and so on and so forth. Right. So if you look at globally, where are people emigrating from, moving out of? Well, in absolute term, if you look at in the absolute term, there's the 5 major countries of where people are emigrating out of include India, Mexico, Russia, Syria, and China, because that's where most people in the world live as well. But if you look at in more of a relative terms, in terms of the portion of the population, then there are other countries like Syria, Afghanistan, you have Democratic Republic of Congo, Somalia, Venezuela. So where 10-15% of the entire population has moved out somewhere. And in next couple of slides, you'll see why people are moving, both in absolute numbers and in relative numbers, why some of these countries with the high relative numbers are moving. It's probably different than why people from India and China are emigrating out. So as I just take an example of Nepal, the country I was born, where I emigrated. So about 2.6 million Nepalis have emigrated. I think that's 2.6 plus 1. I'm the, and plus 2, Dr. Shrestha are the two, the last 2 that emigrated. But joking aside, 2.5 million Nepalis have emigrated somewhere. And if you look at where they have emigrated, then I think this number, 700,000 have emigrated to India, but that's probably is an underestimate. Probably thousands or hundreds of thousands of million probably migrate between India and Nepal during the seasonally. So, but for a longer term, probably 700,000 to India, 600,000 to move to Malaysia, 500,000 to Saudi Arabia, 250,000 to Qatar. And I'll come back to the whole issue of Qatar in a little bit in terms of the health consequences of migration. 175,000 to US and 80,000 to Australia. Just give you an example. And if you look at on the slide, I've sort of separated these 2 categories, UK, Australia versus India, Malaysia, Saudi Arabia, and Qatar. That's because people who move to these Gulf countries or Malaysia probably are different than people who moved, Nepalese who moved to the US and Australia. So that has implications on health, probably, I don't want to generalize too much, but people who moved to the United States and Australia or Western countries are probably have a high level of education. They're probably more professional, move for professional jobs versus the moving to the Gulf countries, Malaysia, it's more of a migrant, the laborers, those. So where are, there's a push factor. People are moving from some of the lower income countries to the high income countries. That the people who are moving to United States actually is the #1 country where most people end up moving to. Germany and last, if you look at the second, and a lot of Gulf countries people are moving into. So let's take an example of the United States. About 15% of the US population right now is born somewhere else, right? And if you look at the map, people in the United States come from everywhere, right? The darker shade is an absolute number of, it's more people have come from those countries, India, China, and a lot of Asian countries, plus Latin American countries, but every country in the world probably has contributed to the immigration in the United States, and that immigration may be documented or undocumented. They used to be called legal alien or illegal aliens. As I said, I used to be a legal alien for 15 or 20 years of my life in the United States until I transitioned to being a permanent resident and a citizen. And this also includes a group of asylees and refugees. So unlike what a migrant is, refugee actually has a specific definition, and that definition came about in 2051 after after the Second World War, where there's a mass exodus of people in Europe, and so the legal definition is owing to well-founded fears of being persecuted because of race, religion, and a few other things, that you are outside the country of your nationality, right? The country of your birth or residence, and you move across the border. And because of that, the country that you belong, your nationality cannot provide you the needed protection, or sometimes it's because of the country or the government in the country that you are refugees, you fled, and you don't want to go back. So you basically cross the national boundaries, and you have been recognized as such. So when that happens, then you have certain protection that every country in the world actually has recognized that definition, and they have obligation to provide you some level of protection if you are a refugee. And so there are about 26 million people in the world are in the state of refugee right now. And where are the refugees coming from? So on the left-hand side, if you look, these are the countries that is contributing to a large number of refugees at the current time. That includes Syria, Venezuela, Afghanistan, South Sudan, Myanmar, or used to be called Burma. If you look at the top 5, that's the 2021 statistics. But I put that in 2022. What happened? Russia invaded Ukraine, and there was an exodus of 4 million people, Ukrainian, moving across Europe. So where are these people going? So if you look at the map on the right-hand side, you will see the countries that are adjacent to the country that are contributing. Like, for example, look at Afghanistan. Where are most Afghani refugees going to? Well, they're going to Pakistan, or in the east, or Iran on the west. We have Turkey, a lot of Syrian refugees are going there. You have Uganda, a lot of people from Democratic Republic of Congo, and so on and so forth. And Germany, a lot of Syrian refugees are traveling across Europe and seeking refuge in Germany. So why is there a refugee crisis? It's because of the political violence, conflict, wars, and sometimes natural disasters are contributing to the refugees. So now it comes to the final terminology, what a resettled refugee is. So when you are a refugee and you cross the national boundary, you can't go back to your country of origin. The country that you have sought asylum and refuge cannot doesn't want to take you in and give you permanent residency. And that's exactly happened to the Bhutanese refugee I'm going to be talking about. So the Bhutanese refugees were residents of Bhutan, which is a country in South Asia, right here where I'm pointing. And it is surrounded by India on three sides, China, Tibet on the north side. It's not connected to Nepal, but 100,000 or 125,000 Bhutanese fled persecution by ethnic majority in Bhutan in early 1990s and fled across India and came to Nepal. These refugees were ethnic Nepalis whose ancestors had migrated from Nepal to Bhutan and lived there for generations. But the government of Bhutan said, well, you actually don't belong here. You don't look like us. You don't speak like us. You don't dress like us. You don't, so you don't belong here. And there was a conflict and people fled, came to Nepal because they spoke Nepali. Their ancestors, they would look like me or Dr. Shrestha or any Nepalis you have seen. And there is no one type of Nepali, just to be clear, but they all spoke Nepali, although they may speak their own dialects. And then in 1991, early 1991, came to Nepal, but Nepali government could not absorb 100,000 Bhutanese of Nepali descent. And Nepal is a country of about 30 million people now, right? At that time, they may be, let's say, 20 million people. 100,000 people, for some reason, Nepal decided, no, we'll grant you refugee status, live in these refugee camps for however long you want to live, but we can't observe you. So they couldn't go back to Bhutan. So between 1991 and 2007, 2006, they lived in a state of limbo, what you call a protected refugee situation. And finally, some of the Western countries, and as you see on the right-hand side where the refugees are being resettled, most of the time it's the Western countries, United States, Western Europe, Australia. They said, okay, we'll take in 100,000, and anybody who wants to come and live, we'll resettle you in a third countries. That's what the process of resettlement. And that's a wonderful thing. But out of 26 million people every year, about maybe 200,000 or 300,000, less than 1% are actually resettled in a third country. So when you do get resettled, then your status changes. You no longer are going to be refugees. So if you're resettled as a refugee, so Bhutanese refugee, they came here as refugees, but within few months, they are permanent resident, the green card holders. And within 5 years, they become full-blooded Americans, red, white, and blue, right? So it's a misnomer when I write about these, what do we want to call them? So they were, some of the children are not even born in Nepal, but their family came as resettled refugees. So if you want to look at health issues among immigrant or refugee population, we have to think both in terms of all the usual determinants of health in epidemiology and public health. We tend to think about individual factors and lifestyle factors, living condition and work conditions that we all are familiar with, as well as community and social factors, and as well as the policies. But overarching in those factors, those are modified by the refugee, the migration experience of these people, right? And these people have gone through an experience of migration, and that sort of modifies the usual determinants of health. So we got to think about their pre-migration experience. Where did they come from? What was the reason for their migration? What was the health status before, or what was the underlying epidemiology condition of the place they migrated from? And also look at what happened during the transition phase, movement of when they moved from one country to the other, or to the third country, and once they arrived to the refugee situation or resettlement, what were the conditions, right? When US resettles, we have 50 states. There are some states in the United States are really good at and want the resettlement of refugees. right? Ohio, you may not believe, is one of those states that actually is fairly welcoming of immigrants and the refugees, versus some other states in the union tend to not have the same attitude. So, types of the policies, as well as the, where they're going to be resettled, what the cultural and linguistic barriers, all of these are going to impact the health issues. And when you do research among refugees, you have to think about it. And the bottom line is actually refugees and immigrant population are one of those vulnerable and health disparate population. We saw that when the COVID pandemic hit, and we saw that in the United States and globally. So these are a couple of headlines during the COVID pandemic that happens. One, both of them are from the New York Times. One says packed with migrant workers, dormitories fueled coronavirus in Singapore. So if you look at the picture, the migrant workers would be from Nepal or India or the surrounding countries, and there would be 20 people living in a dorm. So if there's an coronavirus infection, somebody got infected, it's going to spread into the entire dormitory or entire population in there. On the right side, you have corona cases and deaths were vastly underestimated in US packing plans, a House report says. So if you remember in 2020, when the coronavirus moved into the heartland, there were a lot of meat factories were the epicenters of the COVID infection. And who were working in these meat factories? A lot of immigrant population, a lot of resettled refugees. And these population had a higher mortality, higher infection than the general population. A couple of months ago, all of you, unless you're living under a rock, there was a big global thing happen. What do you call it? Every 4 years, the World Cup happens, right? And if you know anything about World Cup, the soccer or football tournament, it usually happens during the summertime. But 2022 was a special year because it happened in November, December. Yeah, the reason it happened in November, December is in somebody's infinite wisdom, they said, oh, we'll hold the World Cup, we'll hold it in Qatar, one of the hottest places on the earth. So you can't play that during the middle of the summer, so let's move in the winter. So to build the Qatar Olympic Games, there were a lot of migrant workers that would build the stadiums. So I'm sure you have heard about, you've read about the plight of the migrant workers in the Gulf states, the thousands of workers that died building this soccer stadium. And this event actually highlighted the plight of migrant workers. Well, they built 6 or 7 stadiums, but right now that building is continuing in the Gulf states, and Saudi Arabia, there was on the news, what's going to build this massive modern city in the middle of the desert. Well, somebody has to build that. That is going to be built by migrant workers from South Asia. And when you work in the heat at 120 degrees, there are going to be a lot of health issues these migrant workers are suffering. The World Cup kind of brought to the highlight some of the health issues among migrant workers, but that's going to continue. And hopefully the focus doesn't diminish because the spectacle around the World Cup has ended. So, when you're doing health research on migrant health, you got to look at, the ultimate apex of epidemiology pyramid, the deaths, thousands of workers, but there are other health consequences as well, diseases, If you look at one of these pictures, this says Surendra Thamang getting dialysis treatment in Kathmandu on June 28th. This is a fairly young person whose kidneys have been shot. Why did that happen? Well, he was working on 120 degrees heat in the middle of the summer in Qatar or building soccer stadium, and the kidney started malfunctioning. And you'll have a lot of deaths, disability, and other health consequences that need to be looked at. As epidemiologists, that's what we do. We look at the scope of a problem, so something can be done. That's one of the first steps, right? And when you're doing research on the immigrant and refugee population, access to data is not an easy process. So you may have to look at different sources of the data. And when I talk about the actual, the lead research we've done, I'll give you some of the examples of how we had to come up with some of this data and some of the definitions. So you got to look at different health issues from mortality, morbidity, health status, and the risk factors, including nutritional status, health system access, and other determinants, and use different sources of the data. So with that sort of a quick 20-minute introduction, let me go to the issue of childhood lead poisoning or blood lead level in children in refugee children from refugee families. All of us know lead is a heavy metal that doesn't have any biological need, but it is widely used on a lot of things. It used to be used in gasoline worldwide, and paint, and a lot of other industry and commercial applications everywhere. And it tend to accumulate in human body, cause a lot of harm, especially childhood lead exposure. Right? In the United States, we sort of banned use of lead in a lot of products, including gasoline, paint in 1987. Well, globally, everybody didn't follow us immediately. In fact, the last country to ban lead in gasoline was Algeria, and that was in 2021, just a couple of years ago. The reason being, Algeria has a large stockpile of leaded gasoline, and they didn't want to give it us, right? So it's been used. And after the sort of regulation of lead and lead-based paint and gasoline, the lead level in the United States in children have dramatically gone down. But still, if you're a child from lower socioeconomic strata, ethnic minorities, immigrant, and resettled refugee, you're more likely to have a higher blood lead level, and partly because you tend to live in houses that are and in the communities that have high lead levels. And in the last 20 years, there have been some case studies of acute lead poisoning in immigrant children or resettled refugee children. So there have been a lot of attention to several studies that have looked at lead level in resettled refugee children. And because of the nature of who comes in, the refugee population changes, the destination changes. The United States has 3 million resettled refugees since 1980s. And that the profile had changed. It used to be Southeast Asian refugees, and we have Bhutanese refugees, now we have Congolese, European, different. So we want to know, what is is this pattern continuing? So there have been previous studies that have looked at the lead level, and it has consistently been higher in children, resettled refugee children. But the data that used was, was from what you call a post-immigration, post-resettlement health screening. So that means if you are resettled in the United States as a refugee, within 3 months of your arrival in the country, you have to get a health screening. For children, that health screening includes testing for lead. So from that perspective, if you are a child who came to the United States a month ago, you take your blood, we test for your lead, it is highly unlikely most likely that lead exposure that happened probably didn't happen in the United States. Probably that lead exposure was out of the country. So when you look at a lot of studies that have happened related to lead in immigrant children or resettled refugee children, it has used that medical screening. There were no studies, prior to one of the ones I'm going to share you, that has looked at the lead that was acquired in the United States. So we did a couple of studies. One is we looked at the time of resettlement, what is the level of lead in the children. So for that, we also used the post-resettlement refugee medical screening data for 5,661 children who were resettled in Ohio between 2009 and 2016. So again, because this is a required medical screening, you have to get it done within 3 months, and most of the screening is done within the first month. And there's we obtained the data from Ohio Department of Job and Family Services That's the agency in the state of Ohio, that the social service agency that deals with the resettled refugee children. So using that data, what did we find? Well, it turns out, it's no surprise, that 27% of the children, and this is, I'm just presenting the data among children less than 6 years of age, had blood lead level of 5 micrograms per deciliter, higher than 5 micrograms of deciliter. That is an important cutoff point, because in 2012, if you have higher than that blood level, that's a level of concern. You are exposed to, that's a lead level that's going to be harmful. In fact, no level of lead is good for you, but 5, according to the CDC, 97% of the children in the United States would have less than that. So that is the cutoff point that CDC used in 2012. Prior to that, it was actually 10 microgram per deciliter. So the cutoff point is decreased. So if you look at the national prevalence, it was during that time frame, on average, it was about 5%. In Ohio, it was about 7%. So if you are a resettled refugee child, you have 5 or 7% of higher prevalence of blood level greater than 5 microgram per deciliter. And so that's to me an indication of the exposure that happened prior to coming to the United States. But resettled refugee children, that's sort of an aggregate. But if you look at country specific, so for Afghani, if you look at Afghani children, right, it was 75% of the children had a higher blood level than 5 microgram per deciliter. Right? If you are Bhutanese, the children, resettled refugee, you had about 40%. So, on average, every resettled refugee group has a higher rate of higher prevalence of elevated blood level compared to the U.S. population. Right? But within the resettled refugee population, it matters what part of the world you come from. So that's sort of the take-home message from the study. And it also provides us with a window into what is happening out there in the world. Obviously, these children, prior to they were resettled in the United States, they lived in Nepal. They lived in Thailand. If you're from Burmese children, most likely you lived in Thailand. If you are an Afghani children, you probably lived in Pakistan before you came to Nepal. So this gives you what is, would be the lead level in children in those countries. So when you do epidemiologic study on resettled refugee in the United States, it actually has an implication. It gives you a view into what is happening there in the world. So, none of the global health issue things we do are in isolation. So there's always a learning, in the application somewhere else. But more importantly, we also wanted to look at, okay, after they have resettled in the United States, does this lead exposure continue? Or is it after they come here, the exposure stops and they're going to be fine? So to do that, you're going to need a prospective follow-up study. You need a cohort study. So once you are into the country, within 3 months, you are a citizen. I'm sorry, a permanent resident. So there is not a refugee label that continues. So how do you do an epidemiologic study where you don't have a cohort that, unless you have, and a lot of money, you can establish a cohort. This is not a group that, get prioritized. You're not going to get $10 million from NIH to do the study. So how do you do this? Well, we happen to be in an area. Akron Children's Hospital has a outpatient clinic that is, provides healthcare to a lot of US-born children. Also, it is specializing in providing care to children from international background, aka a lot of resettled refugee children actually go into this clinic to get their regular care. Although they don't collect data, they don't ask whether you are refugee or non-refugee children, they do have what the language, primary language spoken at home is one of the data point that is collected by the clinic. Well, that is important. The reason they collect that is because if you need to provide interpretive services for, if your family doesn't speak English, they need to know what language do you speak? Do you speak Nepali? Do you speak Korean? Do you speak Burmese? Or do you speak Spanish? So it happened to have that information. So what we did was primary language spoken at home, we used as a proxy for refugee status. And we can have a discussion on using that in terms of the epidemiology implication, the validity of the study, and I can go into when we do have time. But we're fairly confident if you live in Summit County, Ohio, and if you speak Nepali, it's not because your dad is a professor at Kent State and go to this clinic. It's probably not because your dad is a Kent, because you are resettled as a refugee child. Even if you were, there's less like, there may be a small number of children who are not Nepali speaker that are resettled, that are Nepali speaker at home, but that's not, have substantial implication in the validity of the study. So we used the medical record data from Akron Children's Hospital between 2009 and 2016, and looked at the incidence of blood level. So to do that, we needed to have a child at least need to have 2 visits. They need to have less than 5 micrograms of blood lead at the initial visit. So in the subsequent visit, if they have more than 5, then it's an indication that they acquired that lead in the United States or here. So with that, what did we find? Well, it turns out if you are a child from one of the resettled refugee families, and you spoke Nepali or Burmese or Korean, one of the languages, then you had 3 times, you had a 3 times higher prevalence, or 3.8 times, or 4 times higher prevalence of at the first clinic visit. If you're a Nepali speaker, you have about 5 times. Right? And if you're a Korean speaker, it's about the same, right? That's the first clinic visit, that's the prevalence data. But when you look at the incidence, again, you see the same pattern. You have 6 times or 7 times higher incidence of blood lead level, high blood lead level if you are a resettled refugee child, compared to if you're not, right? Within different subgroups of resettled refugees, Nepali speakers have 8 or 9 times higher than the English speakers. Korean speakers have about 3 times higher incidence, right? So in this study, we actually have control for the zip code. So the question becomes, is it because there's just an environmental factor, and the zip code, controlling for zip code is not, doing the job of, zip code is a fairly large area. If you live in you may live in a cluster of that has a high risk of lead, or is there something else that is going on in addition to the environmental lead exposure? So that's going to be our next sort of a study that follow up to figure out, is it just the environmental exposure to they're living in the houses that are built prior to 1978 and or is it something else in addition to that? We need to figure that out. So this is just an example of, if you are a resettled refugee and, when you come to the United States, you're going to have some of the health issues, but some of the health issues continue beyond. You are one of those vulnerable health disparate population, and that needs to be figured out. We have to understand what the level of that disparity is, what are the reasons for it, and how can we actually address those disparities. So just in a couple of minutes before I stop, so we'll have about 10 minutes of discussion time. So when you do, the immigrant health, I'm using the term immigrant, both that includes refugee as well, it's going to be continuing to be an important public health problem, right? But it's a global health problem, but that has local implications. So Even in Alabama, you're going to have, most likely, even if you live in Alabama, Northeast Ohio, we should be concerned in looking at some of these problems, and we have the opportunity to look at the problem. So a lot of times when you think about global health issues, we got to go to Timbuktu and do some issues. That's still the kind of the prevailing notion about what global health is. If you're a student, you want to engage in a health issue that has a global dimension, you don't necessarily have to go to Timbuktu or Kathmandu. That would be wonderful if you want to go, but you can, do that similar work in the United States. Because 50 million people in the United States were born somewhere else. So, the United States is a reflection of the world a lot of times. And migrant population are vulnerable, marginalized, and they're going to be neglected. It's not a priority, and a lot of times the health research on those population lacks funding. And there are some sources of funding, but a lot of the work that I've done actually has been on more of a shoestring budget. So, and a lot of it has, involved collaboration of local agencies and using the resources that I have. If you look at some of the, some of the organizations and community, the institutions that have collaborated, that included healthcare facilities, social service organization, government agencies. All of these are local in Ohio, as well as I've collaborated with other academics like Dr. Shrestha. And internationally, we've collaborated with NFCC to do our HPV-related work in Nepal in resettled refugee population. So you have to, collaborate with different agencies to secure the data, look at as well as the community organization. The reason I was able to get into the Bhutanese Nepalese community is because I approached the community first as because I was a Nepali speaker, not just because they welcomed me because I was a Nepali speaker, but I earned the trust of the community. Just because I spoke Nepali doesn't mean that they're going to talk to me, but I engaged with the community, and the community support was really important, has been really important for all of the work I've done. And then I've had students work with me, both the US students who don't speak Nepali, but I usually pair them with a Nepali speaking students. And we have, in our program, graduate program, Nepal students from Nepal. So I pair with the US student with the US born student with the Nepali student. So each of them bring their own strengths. So it has been an interesting and, continue to be an interesting work, and it's gonna, the work needs to continue, and there's a lot of opportunities.